Hello, everyone, and welcome to This Week in Hearing. I'm your host, Kathleen Wallace, audiologist, adjunct professor at CUNY Graduate Center, and head of provider education at Tuned, a virtual audiology platform. Today, I'm pleased to be joined by Dr. Barbara Weinstein. Dr. Weinstein received her PhD from Columbia University, where she began her academic career as a young faculty member. A professor and founding executive officer of the Health Sciences Doctoral Programs at the Graduate Center of CUNY, Dr. Weinstein also holds a position as an adjunct professor of medicine at NYU Langone Medical Center in New York City. The author of both editions of Geriatric Audiology, Dr. Weinstein developed the world's most widely used tools to identify patients with hearing loss, which has been translated into 20 plus different languages and is used globally to document the negative health effects associated with age-related hearing loss, as well as the outcomes associated with hearing aid use, audiologic rehabilitation, and counseling. Dr. Weinstein's primary research interests include hearing loss, dementia and social isolation, physician-patient communication, screening of age-related hearing loss, person-centered care delivery, and the quantification of patient-reported outcomes. Dr. Weinstein has long advocated for the integration of hearing healthcare into the mainstream, be it cultural, medical, or religious institutions. Her research has profound implications at the intersection of audiology, public health, and society. She is proud to be selected as a 2022 Distinguished Alumnus for the Teachers College of Columbia University. Dr. Weinstein, thank you so much for joining me today. As an alum of the Grad Center, I can attest to just how prolific your work is and how much of an impact you've had on multiple generations of audiologists. So today's conversation will definitely be an exercise in restraint for me, because given that introduction, we have quite a few aspects that we could be talking about and do warrant further discussion. So we'll just get right to it, but welcome.
Okay, welcome. Thank you for inviting me. I was honored that you reached out. I've been following your career and I've been proud. It's like being a parent, and when students, take off and do their own things and initiate and are contributing to the field, it's kind of like it feels very good as an instructor, as a professor, which is one of the reasons why I have done this for so many decades.
I'm sure. And especially in New York City, you probably have touched the career of almost every audiologist in New York City at this point. So the effect, the ripple effect of CUNY is pretty powerful, and the ripple effect from Teachers College is really powerful. I don't know. It's a shame that program even ever closed, because it does seem like the most prominent figures of audiology, at least in New York City, came from that program.
That's true.
So to start off, mentioned in the intro that perhaps your first claim to fame is the Hearing Handicap Inventory for the elderly or adults, and that it really captures a subjective measurement of hearing difficulty in a way that hasn't been done before, at that point, and still remains perhaps the most widely used tool for audiologists. So what do you think the value is in having these sort of subjective measurements, in addition to the objective measurements we're getting from the traditional audiogram and other diagnostic tests?
Well, what's interesting is that a lot of people think that I did my dissertation in developing the Hearing Handicap Inventory, but I didn't. I did my dissertation on looking at hearing loss and social isolation in the elderly and loneliness in the elderly. And what I learned from that experience from that research was that the pure tone audiogram is not predictive of whether or not somebody with hearing loss is going to experience feeling of isolation. And it's not predictive of their feelings of loneliness, nor is word recognition. But the self-report questionnaire that I used, which was the hearing measurement scale, was the most predictive of some of the psychosocial effects of hearing loss, which I measured in my dissertation. And I realized then that it was important to develop a questionnaire that was focused on older adults, because even in those days, I knew that the projections in terms of life expectancy and hearing loss affects older adults most profoundly. So that's when I joined the faculty at Columbia, I suggested to my mentor, Dr. Ventry, how about developing a self-report questionnaire So basically it was, I think what I saw is that in those days, I recognized that the pure tone audiogram only accounts for a small proportion of the individual variability in the reaction to hearing loss. So there's got to be other variables, and the self-report seems to tap into a lot of different areas, including auditory processing. So in those days, that's when I first started with the hearing handicap scale. And then what happens is we developed the long version, and I was interested in screening, and most audiologists were not really that interested in screening. And I know that time is of essence, time is money for audiologists, even in the 1980s. So I said to Dr. Venture, I said, I'm going to develop a screening tool for screening for hearing loss. And that screening tool ended up becoming widely used, and it's still cited. All the research that we did on the self-report is still cited by the U.S. Preventive Task Force, and most of the research on screening includes the hearing handicap. So the measurement of self-reported handicap, now we know it's predictive of so many different things, which I didn't know, of course, when I developed the questionnaire, including quality of life, including mortality, including some studies dementia, including hospitalization, hearing aid uptake, of course, hearing aid benefits. So it's really predictive of a lot of different areas in healthcare. Most audiologists still are not convinced of the value of the self-report, but with Larry Humes publishing a lot of articles on auditory wellness and measuring auditory wellness using the self-report, and also now Brent Edwards is talking about the value of the self-report. I think that we have the big guns in the field, the bigger guns in the field, the men in the field. And I think that that's really helpful in terms of promoting the self-report, because it really, it does capture what we need to capture to bring people into our clinics. And also with OTC, OTC was interesting, is because the criterion for use of OTC over 18, but self-reported mild to moderate hearing impairment, that's an oxymoron, because you can't have a self-reported mild to moderate hearing impairment, but all the articles that you're reading now are dropping the self-reported and putting in the mild to moderate hearing impairment. So there's a lot of misinformation. And when I wrote and commented, I said, you got to figure out how to self-report, but that fell by the wayside. So it's kind of, so self-report is going to be important. How you self-report, that's another story.
Yeah, and this is probably the most trusted way for us to measure that self-reported aspect of it, which in a lot of ways, I think it's a little polarizing in audiology, as you mentioned. But for most audiologists, of course, having some subjective measurement is crucial for proper care of a patient, because in a lot of ways, it's more important almost than what you're actually seeing, which we see with the hidden hearing loss or auditory processing.
That's exactly right.
We have to go with the subjective measurement.
So with the hidden, what's interesting is that there's now a movement afoot to have a metric for unifying the language in terms of how people understand severity of hearing loss. And there's been, Frank Lin and Nick Reed wrote an article about the value of a metric. They're proponents of the 4-frequency pure tone average. And then Humes and I wrote an article saying that by using the 4-frequency pure tone average as a metric, you're missing the people with hidden hearing loss, 12%, you're missing the people with auditory processing. So that's just a misnomer. So there are definitely different camps out there.
Yeah,
and I think this should be a combined. I think this should be a combined measure, actually,
of
pure tone and
pure tone average,
self-report, and self-report.
Yeah, and I know that Nick Reed and Franklin have been big proponents of having like a number to really quantify
That's
hearing.
right.
They want to have, how we have the 20/20 vision standard. Can we get a number for it? Because it seems like that's something that people want. People want to understand their hearing better, so we do need to simplify it. And I think part of the beauty of the hearing handicap inventory is that it makes it so relatable. It breaks it down, and it makes it something where they really can think of very clear examples and and assess whether it's a yes, a sometimes, and a no. And then all of a sudden they do have a score where maybe their report, if they didn't have those prompts, wouldn't be as robust or accurate. They might say, it happens all the time in the clinic, where they say they don't have a hearing issue. Then you go through the HHIE, all of a sudden they're coming up with, a pretty big score. And then all of a sudden their answers start to change. Like, oh, I guess I do have some hearing issues. So breaking down
Right.
that barrier and relating to patients seems like one of the most powerful benefits of a measurement like the HHIE. Was that part of
Yeah,
the
well,
intent?
no, the part of the intent was just to measure how people were reacting to their hearing loss, because audiologists in the past were really not focused on the reaction to hearing loss. They were mostly focused on diagnostics. So audiology has gone through a lot of, and I said this in a podcast that I was just on, audiologists goes through different waves. Certain areas and topics are popular at different times. So for example, when I went to school for my master's in the 70s, I didn't have a class on admittance. But then, so admittance became popular, and when you went to conventions, the room was filled with all the people interested in learning about admittance. And then it came to when audiologists were allowed to sell hearing aids. Then audiologists became interested in hearing aids, and that was the big thing in audiology. Then we had not cochlear implants, ABR became the technology. That technology became the thing, and then newborn hearing screening. So we've gone through different stages, and technology has always been at the forefront.
Mhm.
And my feeling is that we need to focus on the patient. That was been my focus in the 80s, and that's continued to be my focus. And only now is patient-centered. People have been saying, well, we have to really focus on what the patient says, what the person says, and that's throughout medicine. And we know in terms of self-report, the self-rated health is predictive of longevity. It's predictive of so many things, as is self-rated hearing difficulty.
Mm-hmm. Yeah. So person-centered care, that's even a fairly new term, right? It's putting a name to something that some people have been doing for a while, and it's really sort of gained some steam. IDA Institute's a big part of that. There's different influences there. So to you, what would person-centered care look like? How do you think it's best implemented by an audiologist?
Well, I think the first question when a patient comes into you is to ask about the journey. I mean, just to have the patient talk more about their experience. And if you begin to if you have an open-ended question, you're going to learn a lot about everything you need to know about what's the patient's experience is, and based on that patient experience, that should be the driver of what we assess and our recommendations. So the patient should be the driver and then at the center. And decision making, the patient should be educated about the options, about the findings, about the options, and then patient should work with the audiologist to make the decision. But over and over again, I hear from so many of my friends who I sent to the audiologist, well, the doctor said I'm a candidate for hearing aids because I have a mild to moderate hearing loss, or the doctor said I'm not a candidate for hearing aids because my hearing is not bad enough.
Mm-hmm.
And if we just keep going by the audiogram rather than what the patient's experience is, we're losing out, which
Mm-hmm.
is why I think that's theoretically the beauty of the OTC is because it's more self-rated, but if it gets lost in mild to moderate hearing impairment. But patient-centered care, I mean, the patient should be the one who's driving the decision-making once the audiologist educates. And that's why when you were a student, and now decision aids have been used in medicine. And by offering options to patients, we're educating them, and we have to educate our consumers, and they'll be driving the decisions. So I just think it's a partnership, and that's
Mm-hmm.
what person-centered care is. It's not, you don't look at the audiogram and tell a patient, okay, you need a hearing aid. That's just not the way we should be practicing audiology or medicine.
Yep. Yeah. Where it's
So,
really more almost like a flow chart of, if this person says yes to this, then you have
right.
these two options, and eventually you will get to perhaps a firm recommendation, or at least be able to narrow it down. But I do think the best kind of audiology that could be delivered is almost more of a educator and consultant perspective of providing resources and then ultimately letting the patient choose from there.
Right.
And as you
And
said,
that's going to be, and that will be the future now. If
Mhm.
audiologists embrace this whole OTC thing, we should be the resource, and we should be the expert. We should be the go-to for so many different things. But what's interesting is that I don't know I think that maybe this whole OTC movement will push audiologists in a new direction. I hope in
Mhm.
terms of
Mhm.
being the resource person.
Yeah,
So,
because I think we know from people inside the field, we know that it's not a black and white issue. It's not hearing aids or nothing. We know that there's a whole spectrum of options or solutions out there. And you've always been a big proponent for things as simple as a pocket talker or an app, or, all the way up to other assistive listening devices to a hearing aid, or a cochlear implant, and having that full range is going to have to be crucial for audiologists to be able to talk about it. And I think you've always been a very big proponent of that, of having options and not necessarily viewing it as hearing aids or nothing. Would you say that you're an embracer of technology other than hearing aids?
yeah, so that's, I'm very, very concerned about the fact that not enough audiologists are referring patients for are talking to their patients about all the options out there. So we
Mhm.
should, when we speak to our patients about the options, we should tell them about the smorgasbord of options from an OTC all the way to a cochlear implant, because people will be hopeful. Well, if one thing is not working, then we can go to the next stage of technology and the next stage. And what's disappointing, I referred a number of people to cochlear implants for cochlear implants, and the spouse, the person who got the implant, said they each say independently, it's life changing. It saved our relationship. It saved our marriage. And why didn't my audiologist refer me for this? Because I'm the one who's pushed them. And I
Mhm.
think that I think we have a responsibility actually to screen for residual disability and to tell doctors, primary care doctors, we're talking about trying to get primary care doctors to do some screening. There'll be a couple of articles coming out by Dubno on screening in primary care practices. But what we should be doing is be screening for residual disability as well. Doctors should, so you have a hearing aid, how you doing with the hearing aid? Is it working? And we need to measure with the self-report questionnaire, for example, the hearing handicap, how they're doing, even though they have the hearing aid, even though they have it using accessories. If you look at the research on cochlear implants, the average hearing handicap inventory score of people getting implants is about 60
Mhm.
out of 100. So what is it? Why do people have to suffer that much and have that kind of severe disability before they end up finally saying, all right, enough is enough? I think we have a real obligation, and it's very sad that audiologists are not making the referrals, and educating doctors about cochlear implant candidacy, I think may be helpful.
Mhm. Yeah, and I think it's a big part of building trust with the patient too when you're offering more than one option. If you just say it's
Right.
hearing aids, if you give them a full range, I feel like that's far more trustworthy, especially when you have a great range of, level of complexity, of price. It's varied on a lot of perspectives, from something as simple as an app to a surgery of cochlear
Yeah.
implants. And that is really important for the patient trust. But what you said about the primary care physicians, that's a good segue of a lot of your work has been very interdisciplinary, where you are working outside of the audiology bubble with primary care providers, gerontologists, lots of different specialties, because as you capture in the hearing handicap inventory, there are all of these larger ramifications for hearing loss. And a lot of these other providers are the touch point for the patient. So can you talk a little bit about the research that you're currently doing, or and why you think that's important for us to think outside of that audiology bubble and reach out to these professionals?
And what's interesting is that just of late, within the past 5 years, a lot of a lot of researchers are publishing in non-audiology journals, and publishing about the effects of hearing loss, in terms of all different health outcomes, in terms of costs of medical care, in terms of access to medical care. And I was fortunate enough that a colleague of mine, a present colleague of mine, who you know, just a couple of years ago, who was an MD and PhD, just reached out to me because she wanted to get involved in some research with hearing loss. And she has her own hearing loss. And basically, my dream was always to work with MDs, to educate MDs about hearing and the value of hearing, because I think that that was the way for us to make our greatest impact. So I'm ending up as part of a team at NYU with geriatricians, with public health, with statisticians, with nurse practitioners, with the whole team, and we're working on at this point, we've written a lot of articles on activation in terms what activates individuals to take action in terms of health and hearing, hospital readmissions, and at present, the doctors, we're really interested in reaching people when they enter the healthcare system. So we've been doing a study funded by the Veterans Administration. The pilot was at the Manhattan VA, looking at screening people for hearing disabilities using the self-report, giving them a personal amplifier, and then seeing if the ability to hear the doctors, hear better, understand better in emergency rooms affects outcomes, reduces the number of hospital readmissions, and looking at preferences in terms of their using hearing aid versus the personal amplifier. So that study, we've published that study, and we did show that using this personal amplifier among veterans who get the best hearing aids, they're finding them of this personal amplifier is of great value, especially in emergency room, which is so noisy. And we're now expanding the study to 5 more VA hospitals throughout the country. So that's really good. So an entry point for screening for hearing loss, hearing difficulties might be an emergency room. And my colleague, Josh Chodos, who's the head of geriatrics at NYU, interestingly, his father was an ENT doctor, so interestingly, he's interested in ears, and of course, he's a geriatrician, and he's head of the dementia clinic, and he's now requiring every single patient in the clinic get a hearing test and self-report. We also social isolation and loneliness is another one of my passions. People were not interested when I published that article on social isolation and loneliness, but now obviously it's big. We did a little bit of study in a independent living facility with people who were socially isolated. And we screened their hearing and pure tones and self-report. And then we did give them personal amplifier to see if that helped them get more engaged. And that was the case, that they became more engaged. So, and then the activation studies, another public health, because my colleague Jan Bluestein is a public health person in addition to an MD. She was interested in patient activation. What motivates people to take action for their health or for the hearing health? And what we did find was that older adults with hearing difficulties are less activated. They don't take ownership. They don't go in, and we have to work to activate our patients, to educate the patients. And we know that this is an issue with people with don't have the means. So people who are low health literacy, which is another area of mine. We have to really educate these people, because these people are definitely falling through the cracks. And perhaps the OTC will reach that population, but I'm not so sure it's gonna, because of the lack of health literacy and lack of understanding about hearing. So trying to educate the public about hearing difficulty. I think, did you do that project with the PSA? You did that project with the PSA. Yep. Yeah, that was a great project. And educating people about the public health aspects of hearing is really, really important. And our professional organizations have not yet cracked that nut. So that's what we're doing. And publishing in the medical journals has been really. I actually will say that COVID and the the issue of masking. The masking of the face has made people realize how frustrating it can be to not understand people. But the problem is, this weekend, a couple of people I've ran into, they're not wearing the hearing aid. So why aren't wearing a hearing aid? It's such a pain in the neck because of the mask. I keep losing my hearing aids. So this is a real issue. It's real interesting, but it's raised awareness about and sensitivity about hearing difficulty.
Yeah, I think that the functioning outside of the audiology bubble, it does seem like you are moving the needle far more than all of our internal research within audiology that we are publishing just in our audiology bubble. And what comes to mind is the recent Cleveland Clinic study about the low hearing healthcare literacy of physicians or nurse practitioners and PAs. Have you come across that? Is hearing loss on these people's radars when you are presenting these studies, or What's the reception been for the people outside of the audiology bubble? We've known things for a while. Is it new information to everybody else?
Well, I'll give you an example of a colleague, a friend and a colleague, who's a psychiatrist. And about 8 years ago, I was really excited. I was coming up with a grant for screening for hearing loss for doctors for screening in primary care and referring for hearing aids or other technologies. And I said, I'm really excited. Can I share my idea about how you could screen, how you can refer? And he said to me, he's a psychiatrist. He said to me, Barbara, this is about 8 years ago. Why would I screen somebody for hearing loss if hearing aids don't work? And it's like, wow, that's kind of interesting. And that's when I got a couple of my students, maybe in your cohort, to do studies, surveys of physicians in terms of what they know about hearing loss and what they know about hearing aids. And fast forward 4 years ago, he said to me, Barbara, I've heard that there's a link between hearing loss and dementia. Can you tell me a little bit about that? And can you tell me a little bit about what role hearing aids might play in that regard? And I told him, and he read the literature, and I shared the literature with him. And he's a hearing aid user now, and and it's made a difference in his life. So, and then I have another friend who was on the cusp. He had a significant hearing handicaps and self-report. His hearing loss was on the borderline. He's an attorney, and he said, Barbara, what do you think I should do? And I shared the literature about hearing aids and hearing aid use and the moving of the temporal lobe into the occipital if you don't use your hearing, and sensory deprivation, the value of hearing aids. So he too got hearing aids. So I just think that the more people understand that, the earlier people are identified in terms of hearing loss, like the Lancet suggests midlife identification, because earlier adoption, even a personal amplifier, that's going to lead to earlier adoption. That can make a difference. And I think that's really kind of, but the stigma, there's still this stigma with hearing loss and hearing aids. And I think that one of the problems with one of the contributors to the stigma is that manufacturers keep making the hearing aids smaller and smaller and less visible, making it more and more difficult for people who need the hearing aids to use them. If you could see that somebody's got a hearing loss, you're going to modify your behavior if it becomes more acceptable. Maybe with the OTC, it'll become like people walk around with these AirPods in their ear. I mean, so nobody cares how they look.
So what do you think an audiologist's role is in OTC? There's still a lot unknown about what exactly these OTCs will look like. There's a lot of promise for how effective they could be, if they have, if it's used appropriately, if they're given enough resources, if audiologists, frankly, buy into the concept. What do you think what do you think the role of an audiologist is as we shift to OTC, or even healthcare professionals at large, since you do interact with a lot of other specialists?
Yeah. So I've been a proponent of OTC, and I've advocated when I've written articles in non-referee journals about the value of making less affordable devices, more affordable devices available. I do not think that the OTC is going to make hearing aids more affordable. And I think that, so that's just affordability is an issue, and hearing aid prices are not going to come down because audiologists continue to say, and will continue to say, it's not the price of the hearing aid that's costly, it's the service. So it's really, really important for audiologists to start unbundling. And if people get used to, and if audiologists unbundle and charge for their services, for their education, for the value added of working with an audiologist, that can be important. So we should be the go-to professional for advice, and we should charge for our services, and we should be helping people live with hearing loss rather than use hearing aids. And I think most audiologists spend more time with the technology And then by the time they finish with the technology, the patient doesn't want to come back anymore because, I mean, you go back 3 or 4 times and they're tired of going back. Patients,
Yep.
some audiologists, oh, feel patients, they like me, they like to come back. You haven't even gotten to the patient living with the hearing loss because you don't have time, and you're not, and they're just, the audiologist has to focus on the patient and the not the technology. And with OTC, this is a chance. People are going to buy the OTC, and then they're going to realize, well, it's more than just the technology. And also, if you're not tech savvy, they're going to need the audiologist. So there's, and maybe there are going to be so many choices, it's going to be hard for people to really understand. For older adults, for certain older adults, it's going to be difficult, and I still contend they're going to need the advice of an audiologist. But audiologists should not be considered hearing aid salespeople. So I think you were at the HLAA meeting when we spoke to the HLAA group, and I did a survey of that group, and the question was, if you wanted advice or counseling about how to live with hearing loss, how to communicate with people with hearing loss, about the feelings and the effects of hearing loss, who would you go to? And the HLAA people said, I wouldn't go to an audiologist, or you're a hearing aid salesperson. You don't know anything about how to live with hearing loss. That's just, that's our future.
That's been a long-standing issue for audiology, of separating the professional from the product. They've become synonymous when they're not, and it does go back to the person-centered care. And it also goes back to how your research, part of why it is so prolific and valuable to audiology is because it is, and I say this in a very flattering way, it's practical information. It's information that actually is going to be digestible and understandable by people outside of the audiology bubble. People can understand social isolation and loneliness and quality of life. They can understand these concepts that are affecting overall well-being and the role of hearing healthcare in that. Where it seems like sometimes in audiology, we sort of lose the forest for the trees, and we get so technical, nitty gritty, that OTC could be this real opportunity to separate those two again and focus on that person-centered care. Is there anything that you would be changing with with the HHIE today, or or audiology? The curriculum, I'm with you.
I would change the curriculum.
And how so?
For example, I think that teaching about hearing aids in one class, and then cochlear implants in another class, and then children in another class. And oral rehab in another class. It's all part of the same package. So that's why you learn all about hearing aids and you don't connect it to cochlear implants, because it's not taught together, and it should be taught together. So I just think you should have like pediatric, geriatric, and then all the other, and the areas connected. And that's how I would present audiology. And I think also we need to get outside of, we need more classes in counseling. We need people to feel more confident counseling and knowing how to work with patients. Now, the studies out of Australia in terms of the amount of time patients spend talking versus the audiologists spend talking, it's absurd. But audiologists are just, they don't feel comfortable not talking, and they don't feel comfortable when talking about the patient feelings. So I think the future of audiology is in rehab and counseling and in communication strategies. And I think that it's interesting. I just did a podcast about dementia and hearing loss, because that was my second, after my social isolation study, the Hearing Handicap Inventory. I did a study on hearing loss and dementia, the first study on dementia and hearing loss. And he interestingly said that he thinks that cognition and measuring cognition, screening for cognition, and somehow working it into the evaluation is going to be the future for audiology, which is kind of interesting. But I think, and I think that is true if audiologists understand better the impacts of cognitive issues on hearing, but even if you have normal hearing, on processing. So
Mhm.
I think there's a lot we out, and then balance, of course, and tinnitus. I mean, all these different areas. These are the things nobody else is doing it, and we should be owning it. When students come in to start and come in and they're applying for audiology, they say, I want to. A lot of them want to come in because they see cochlear implants and they want to really make a difference in people's lives. When
Mhm.
students graduate, what they say is that I want to work with hearing aids. They
Mhm.
come in wanting to work with, come in wanting to work with the person, they leave wanting to work with the technology. There's something wrong with that.
Yeah, yeah, and yeah, something's happening during the 4 years, and I think a big part of it is the modeling of, being very mindful of what environments you're exposing these students to, and making sure that they're audiologists that are, setting a good example. And to your point about potentially expanding more into, brain health and dementia, only if audiologists are well trained and qualified to do so, because obviously that's a very slippery slope, and I think people should be cautious of that. But it does seem like there needs to be more emphasis on critical thinking, perhaps, is the easiest way to put it, of connecting those dots, as you said. We're viewing things in
And
vacuums, and we're not
yeah,
thinking that a hearing aid candidate could quickly shift into a cochlear implant candidate, or shift into even an overlying auditory processing. These things happen together, in
right.
conjunction. It's never just one thing at a time. Um, and as far as the clinical practice of audiology, what do you think you mentioned a focus more on some of the specialties and what audiologists can do that nobody else can do. Um, why do you think so few audiologists actually offer these services? Tinnitus, for example, auditory processing disorders, oral rehabilitation. Sometimes it can be hard to find, even in a major city like New York City. Why do you think that is?
Well, I think that, why the OTC Act was passed, because of accessibility and affordability. And I think it's the same thing with affordability, with hearing aids, is affordable, and not going into other areas. It's because they can't afford to, because they're not going to make the money that they want to make. So, why wouldn't audiologists have in their practice all the different I tried to start a business with some people in terms of selling hearing aids, hearing assistive technology,
Hmm.
and it was very difficult. We couldn't do it. But and some audiologists don't carry this assistive technology. Like,
Hmm.
why don't you carry this, and why do they don't? Because they can't make enough money on it.
Hmm.
But you can make money if you charge. Psychiatrists can charge $500, and people are going to pay out of pocket. So if we have the physical therapy, physical therapists, people go to physical therapists, people go to occupational therapists. They're going to pay for this because it's making a difference in their lives.
Hmm.
Audiologists have to believe in their value. In my
Hmm.
opinion, if they started measuring their value by measuring outcomes after a patient comes in, and following patients and saying every year, come in for your hearing check. It's, there could be a change. We have to reach out, we have to bring patients in. But audiology, so I consulted an audiology practice. I said, send out a hearing handicap inventory every year to your patient. Hello, talk to them, how you doing? And if you score this, come in, we'll talk. Maybe we may have to make adjustments. But then the issue is, well, then I have to charge for that visit, and they're not used to paying. So
Hmm.
the patients are not used to paying, because everything is bundled, and the audiologist is uncomfortable charging. And that has to change if we're going to, I think if we're going to survive as a profession. This
Hmm.
unbundling is really important. And the
Yeah.
telehealth, I think telehealth is important. I think telehealth is great in terms of reaching out, making sure that people are using the technology correctly, seeing how they're doing it. So, for example, I think I might have told you this. I was once part of a grant where we educated. It was a grant to teach older adults how to use technology. This was 20 years ago, and
Hmm.
because none of them used hearing aids, none of them used computers. So we got money. We sent students into the homes. We got the computers into the home. We had the students go into the home and teach them how to use the computers. And then I taught 2 courses to these lay people on hearing loss and hearing aids, and was fascinating. So this was before Zoom, and it was fascinating because these people, I knew the audiograms, I had the audiograms because I said, everybody's got to have the hearing tested who's being part of the study. And they would show me their hearing aid and they would show me how they were operating it. And then I would show them, I would be able to communicate with them, over the computer. And I think that there's a real place for telehealth, but I don't think in terms of programming hearing aids, I don't think that's where it's at. I think it's more on this face-to-face and helping people communicate better, knowing what the problems are, helping them put in. So I think there's a role for it. But in terms of remote programming, you're going to need somebody to help it. That's going to be just that. I think you need to come into the audiologist office.
But I do think it has a lot of potential with the counseling and patient education aspect, which is a giant niche that needs to be filled in audiology. We are in the age of Dr. Google. Everyone's Googling everything. Yeah. And people want to do their research. People want to be informed consumers, which is why the decision aids are so powerful. That's why being separate from the device is so crucial for audiology. There's so much information that people want to know. And it is interesting that audiologists, it seems like we have a major PR issue where, we feel like we can't charge for our time sometimes because it's not perceived value to other people. Why is it not perceived value? Because we're not effectively communicating our value to the world outside of the audiology bubble again.
Yeah, well, in terms of, just sorry to interrupt, but outside of the audiology bubble, I think that it's really, really critical that when a patient is referred to us and we have to write a report to a doctor, for example, the report to severity of hearing loss, admittance, this, the most important thing is patient got hearing aids, patient's hearing aids, patient is using the hearing aid in many situations, patients is no longer feeling their auditory wellness has improved and they're more engaged with individuals, and we recommend that they continue to engage because the hearing aid is making a difference. We need to communicate that to primary care doctors and geriatricians because patients only go in and complain, oh, my hearing aid's not working, but they don't talk about how well they're doing, what a difference it's making. And I think we need to be the ones to advocate for that in our reports. I mean, and that's because doctors are going to read that. I also think we have to make sure I think we have to also counsel patients, and this could be something that they should pay for, how to advocate for themselves. So if doctors are not going to modify their behavior, we need to train our patients to advocate for themselves in terms of when they have their medical appointments and when they go into hospital, when they're admitted to a hospital. Don't leave your hearing aid behind, bring your hearing aid, but this is what you do. So there's so many roles that we can play in terms of education and living with hearing loss.
Yeah, and you mentioned HLAA a bit ago, and going to an HLAA meeting really should be mandatory for audiologists to really get a glimpse into what people with hearing loss are saying and thinking, and honestly what they view audiologists as, because I think traditionally, or at least lately, a lot of that burden of educating people on how to live with hearing loss has been coming from other people with hearing loss, which is great. There's absolutely no replacement for that firsthand experience, but it should be in conjunction with audiologists. And at least it seems like from HLAA involvement that I've had, that is not the perception that people with hearing loss have. We're not that trusted professional or ally to them as much as we should be.
Well, the HLAA people were very strong advocates for this OTC, and they were very, very outspoken because they're really, and their website is amazing in terms of all the educational material. So that's a resource, and audiologists should be referring people to the HLAA website, to the HLAA meetings, local, national, because they really are very educational, and you can patient. But most audiologists don't really have much experience. Well, not much experience. They don't really understand exactly necessarily what it's like to live with a hearing loss unless they hear from the hearing impaired person, which is why Shari Eberts, who I think came to you were there. So Shari is now on she wrote this amazing book, which I'm buying, which hopefully purchasing for every single student in the program, because it's that important for them to read from the perspective of Gail and Shari. But audiologists are really not listening enough to the patient and really understanding what it's like, and even though you're working with patients with hearing loss all the time, I don't know, just getting it from the viewpoint of the perspective of a hearing impaired person is important. That's why the assignment I was the one who said we should have counseling for a semester, not to talk about audiology counseling, just talk about counseling in general. The first assignment is for students to interview people with hearing loss so that they can understand what it's like to have hearing loss. And then ask patients if they know people with hearing loss, if they know the name of their audiologist, and they don't. So why don't people, every single time I see somebody with a hearing aid, I say, so who's your audiologist? Because I may know them. And nobody remembers their audiologist's name. It's really upsetting, but you know your doctor's name.
So we have a lot of work to do.
I think so. So that's why I'm gonna stick with it. I mean, when I go speak at different meetings, and I think that people think she's still around, she's still alive. But yeah, I'm gonna continue to be around and be an advocate for hearing loss, hopefully for a long time into the future.
And on that note, just a few closing thoughts. Where do you think the future of audiology is? You know, there seems to be some traps and some potential. What do you, given your career, what do you advise or foresee as the most promising future path for audiology?
I mean, I think we really have to be trusted members of healthcare teams. And I think that that's really, really important. I mean, orthopedists would not do anything without referring a patient to a physical therapist. And we should, I mean, if you have these different medical conditions, diabetes, heart disease, dementia, falls, the audiologist could be such an important person in the lives of these people. So I think that we really have to become more integral parts of healthcare teams, trusted members of healthcare teams. Right now, most audiologists working in hospitals, for example, they're in part of ENT. And they're so busy with the ENT patients that they don't even have to reach out to other services because they're so busy. We need to reach out, and we need to be more integral to the healthcare team and I personally think that every single patient who's admitted to a hospital, there should be some sort of a record about hearing status and a note on the chart, difficulty communicating. And I think there should be universal communication signs, just like there are universal infection control and that. So I think, because communication in hospital settings is really, really important. And so I think hearing and communication need to be more linked, because most doctors don't know that hearing is essential to communication. And we did do a study on that, and we found that the studies on communication very rarely mentioned hearing, which is so we have to be part of the healthcare team. People have to understand that hearing and communication are critical, and hearing is critical to well-being in people who are being treated for many medical conditions. I don't know if I
think that's a lot to work with.
That's my opinion.
I think that's a lot to work with.
The future could be bright.
Yes. Yeah. And I think that's the biggest thing with audiology is there are plenty of opportunities if we're going in the right direction, if we fight the right battles, if we keep trying to harp on the same things, then yes, we're going to be digging ourselves in a hole potentially. But broader horizons, there are plenty of things to do with audiology, which I think is a very important message right now, certainly from someone that has had such an illustrious career in audiology, is involved in the education of audiologists, and has one of the biggest name recognitions outside of audiology, which is so important to have a good spokesperson for audiology outside of audiology for healthcare at large.
Just one note about that illustriousness. So my daughter, who's she's 30 now, and she was 28, she says, I met my boyfriend's parents, and they said, well, what do you do? And what does your mother do? And she said to me, I really don't know what you do, Mom. I know you're famous. I know you speak. I just don't even know what you do. It was very, very funny.
That sounds like a typical, child reaction where it's like you're a little too close to the sun. You don't know what's going on, but everybody else does. Everybody else in audiology knows. Well, thank you so much for for being on the podcast today and having me interview you. I really do appreciate it. And everyone listening out there, I encourage you to take these words and run with it. And we really do need to do our part of thinking outside of that audiology bubble and making sure that we are promoting the profession and our expertise effectively to other healthcare professionals and working with them for the sake of our patients. So thank you very much, Dr. Weinstein. It was my pleasure to have you.
Thank you. This is wonderful. Thank you so much. And good luck. And hopefully I'm sure I'll see you soon. Thank you so much. Take care.